consent and complications, and I want to try and talk in general about what consent is rather than something specific to a procedure, which hopefully will give you some insights into how you think about what you say to patients when you consent patients for when you're having to make the decisions about what consent should be going forwards. We'll start off with an ECG. So your fun with ECGs for today is this ECG. Can anybody tell me what this ECG shows? So sinus and pacing. Very good. So we can see that we have atrial pacing spike and a ventricular pacing spike. So we know that this patient is in sinus rhythm. The P wave axis is quite difficult to see the P waves, but you can see a P wave here. You see it best in lead 2. If you can't see a P wave well in lead 2, the other place often to go for it is V1. And here can you see you've got slightly inverted P wave. Very often paced P waves don't look like normal P waves, but we know that it's there because of this deflection from the baseline and because of the atrial pacing spike. And then can you see that there's a delay of about 200 milliseconds and the or maybe 160 milliseconds, and then we have ventricular pacing followed by ventricular QRS. This is left bundle branch block. Typically a pacemaker lead is placed in the right ventricular apex. So this is a left bundle of right ventricular pacing. So we have sinus rhythm and dual chamber pacing. Good, so that was really your starter for 10. Now what does this ECG show? So Dr. Al has said complete heart block. Not quite as simple as that. So think about the previous ECG I've shown you. So this ECG, we have atrial pacing and ventricular pacing. This ECG, can you see that there are also pacing spikes on it? Pacing spikes are often not that visible these days to the naked eye with a biventricular, with a bipolar lead. So both of the electrical pulses come from very close to the lead tip, as opposed to unipolar leads where it was pacing between the lead tip and the pacemaker box. And it showed much more prominent spikes like these ones. But the little rectangular pulse of electricity is very non-physiological, so it's very easy for a computer to pick it out. And so usually ECGs will mark your pacing spikes quite nicely, which this one hasn't done. So now I'm saying not, I've got this suggestion that it's not capturing. So that's part of what I'm after. Can anybody give me a full answer to what is going on here? That's maybe quite difficult to give me a full answer. So here we have sinus rhythm in the atrium, and at the start we have sinus rhythm and ventricular activation coming after the sinus beat. And you can't see the pacing spikes very well in these leads, but if you look at the morphology, in lead 2 is the rhythm strip and is recorded all the way along. Can you see how the morphology is identical for these beats as it is for the pace beats up here? So although you can't see the pacing spikes very well in lead 2, you can be sure from that that these are paced QRS beats. So you can see at the start that we have atrial sensing. There's no pacing spike by the P waves. Atrial sensed, ventricular paced, and that's happening correctly for the first 3 beats. But then this one is dropped, as is this one and as are these two. And here you can see the pacing spikes very well in V6. You can see that there's a pacing spike coming after the P wave, but that isn't capturing the ventricle. So this is intermittently capturing. So we've probably had displacement of the right ventricular lead, or something has happened to our right ventricular lead, which means that sometimes it's successfully pacing and sometimes it isn't. So this is a pacemaker that isn't working properly, probably because of something wrong with the lead. We don't know exactly what. And the underlying rhythm probably was complete heart block. We can't see any intrinsic rhythm. So sometimes when a patient with complete heart block gets paced all the times, they end up with no underlying rhythm, and that's particularly concerning if they were to have a problem with their pacemaker, because they might have asystole if it stopped working, which would obviously be very bad news. Great, so moving on to consent and complications. And just to sort of start the flavour for this, let's have a quick case vignette. Let's imagine a lady, and we are looking after her with her presentation with cough and green sputum and shortness of breath. And she's also complaining of bits of chest pain. And over the last few months, she's not been feeling right, and she's been losing weight. If we ask her about her past medical history, it turns out that she's had a chest infection with a similar sort of presentation 2 months ago. And she's not had a good 6 months to the last sort of year or so. She's had a left hip replacement 3 months ago, and she was feeling pretty rubbish for a while and blacking out, which led to the diagnosis of complete heart block, and she had the pacemaker put in 6 months ago. And in the background, she's a type 2 diabetic. She's not on many medications, metformin, ramipril, and atorvastatin. And she, on examination, is pyrexial. She's got a pulse of 60, paced. Her blood pressure is 130 over 86. Normal heart sounds, and she's slightly tachypneic, but normal saturations. So what are we thinking so far about this? My apologies, I need to correct this slide. It shouldn't show the past medical history and medications twice. But what are we thinking about this patient? If we just go back, if anybody's just joined us, so this is a lady with a cough and green sputum and shortness of breath, bits of chest pain, malaise and weight loss. And you can read through the past medical history and medications. What are your thoughts about this patient? I'll give you her bloods. So she's got mild anemia with a raised white cell count, and she's got reasonable renal function, slightly low sodium, moderately raised CRP, and very raised D-dimer. So we've got suggestions of chest infection, yep, and then somebody else suggested CAP, which I believe stands for community-acquired pneumonia. Correct me if I'm wrong. So this does look like a chest infection. Are you thinking anything else? Pulmonary embolism, yeah. So that would fit with the chest pain and the recent hip replacement surgery. Can anybody think of anything else? So this is based on a real case that I looked after quite a long while ago. And we did an ECG, which looked fine, appropriately similar to the one that I showed you at the start. Her chest x-ray showed evidence of a chest infection. But when we did an echocardiogram, we didn't really see anything, actually. It was only when she, after initially improving with antibiotics, she became pyrexial and unwell again, that I went back and thought I'd scan her again just in case. And I saw this. So we've had a suggestion now, infected wire. So I think that's exactly what I was wanting you to think about. So pacemaker infections, you can have infection around the device, it's the box, which are always very obvious, but you can also have infection on the leads or endocarditis, infection of the valves. And this is often less clear cut when it's on the right side of the heart. Often these are relatively indolent bugs because they've been introduced at the time of the procedure. And here, can you see this is a big 2 centimeter or so vegetation flapping around on the pacemaker lead. And in fact, I showed this to one of my colleagues who said, "Oh, I must go and scan that because I've never scanned anything like that, and it's good experience for me, and it's one for my portfolio." So they went and tried to do a scan of this lady, and that lump had disappeared. And that was why we didn't see it on the first scan, because the vegetation was forming and breaking off and seeding pulmonary emboli and infection. So this is a recurrent chest infection caused by an infected pacemaker lead, and the pacemaker had to come out, which is quite easy after 6 months. If a pacemaker has been in for years, it becomes very firmly attached and it becomes very hard to get it out. But within the first year or so, usually it all just slides out very easily. So straightforward to remove. The problem is that you then have to clear the infection for the next month, 6 weeks, and then put a new pacemaker in, assuming there's a strong reason for a pacemaker in the first place. So that is really troublesome, and you need to do something for the heart in the interim, of course, because if she's got complete heart block and is now pacemaker dependent, you need to then temporarily pace her for the duration. And so if you have to put a temporary pacemaker in, you risk the infection jumping onto the artificial material. It can be very, very challenging. Good. So let's move on now to think a bit more about consent and complications. And I want to start off by talking about what people perceive as risk. So what a patient might think of as risk is probably quite different from what you might think of as risk. And I then want to talk about what really is a complication, because obviously there are risks attached to procedures and things can happen that are not necessarily complications. Then I'm going to talk a bit more about what actually are the complication rates and all the factors that are involved in complication rates. So, how do you know what to write on the consent form that you're consenting your patient for, whatever you're planning on doing to them? I'll then talk a bit more about what the actual complications of pacemaker implants are to sort of put it in context, but that's the kind of information which is of great interest to some of you, of less interest to others of you. So I won't spend a huge amount of time going over that. And when I do, I'll talk about the bits that I think are of relevance to everyone more than anything. And then I'll also show you what we actually tell our patients. So what is a patient's perception of risk? What is your perception of risk? So if I put up a statement, there's a 20% chance of rain. What does that mean to you? We're always complaining about the weather forecast, aren't we? If it says 20% chance of rain, what does that mean to you? Does that mean you can go without your coat to work? Well, for most people, they would fall into one of these two camps. They would either be the 80% who didn't get rained on, and they might be happy that it didn't rain, but they'd sort of say, well, it said that it might rain, so why didn't it? They've got it wrong. Or if you're the people who got rained on, they're going to very much say, look, there was only 20% chance of rain. Why did it rain on me? They must have been wrong. And this is the difficulty, because people don't experience risk like machines. if you spoke to somebody the week before we locked down for COVID-19, the chances were they were merrily going about their way, believing that it was all a lot of fuss about nothing. And that gets them by the 99% of the time. People are not really there to deal with catastrophes. And most people, I tried to persuade people in a church meeting that we should talk about what we do with COVID-19 and the inability to do anything else. And we insisted on spending 2 hours talking about meetings that we were going to have going forwards the next year that I kept on saying were going to be cancelled before we finally got onto the subject I wanted to talk about. I mean, it's hard to see things the way that probabilities might tell us. And so when you tell patients that there is a risk of something happening, they very often will fall much more into this camp that it either happens to them and they think you must have been wrong, that it was going to happen anyway, or if it doesn't happen, or they fall into the camp of they think everything's going to be fine for them and they're prepared to take a gamble and just not see it as something that really will happen to them. So try and understand perceptions of patients' perception of risk. What about the national lottery? I mean, national lottery is a great example of something that we just would be insane to waste our money on. I mean, your chances of matching all 6 numbers are 1 in 45 million. You know, why on earth would you waste your time and energy buying a lottery ticket? Has anybody bought a lottery ticket? Would anybody like to know a foolproof way of improving your chances of winning the national lottery? Absolutely foolproof, no trick involved. I can at least double your chances of winning the national lottery in the next few seconds. Can anybody tell me how I do it? The answer is not buy 2 tickets. So I've only had one person answer they've never bought a lottery ticket. I'm obviously, this is the wrong audience for this absolute jewel of a piece of information. So if you buy 1 lottery ticket every minute for the next 90 years, the chances are that 1 ticket will win the lottery jackpot. So you're probably saying to me, oh, that sounds better than I thought. But how can you improve your chances? Well, if you buy the ticket on the day, you're much less likely to have died before the draw. So if you want to win the lottery, buy the ticket on the day, because if you buy it more than 24 hours beforehand, your risk of dying is higher than your chance of winning. Good news. So what actually is a complication? Having addressed what the perception of risk is and the fact that people's perception often isn't matching up with the real probabilities, and the way they think just doesn't connect with probability. What actually is a complication? So there are different categories. A complication can be defined as any deviation from the normal post-operative course. So that's a relatively straightforward definition to have in mind. But things may happen as a result of the surgery that the patient feels are a complication. I mean, if they have a cardiac bypass operation, they're going to have their sternum opened up. They're going to have a very painful chest. That we would say is part of the normal post-operative course. But we also use the term sequelae for conditions that are inherent in the procedure and thus will inevitably occur. So pain from their sternum is a sequelae of the operation as opposed to a complication of the operation. So it's helpful to have terms that describe different things. And there is one more thing to bear in mind, which is failure to cure. So if I do an operation and say not that I would, but say somebody operates on a cancer and tries to remove the cancer and doesn't succeed in removing the cancer, you wouldn't say that that was a complication of the procedure. You'd describe that as a failure to cure. Now, the failure to cure might be because of my skill as a cancer surgeon falling below the standard necessary to cure the patient, but it might also be that it was just bad luck. So there's a subtle difference there between failure to cure and complication. So have those different terms in mind when you think about what I'm going to show you in the next slides. So a complication, a full definition, would be any deviation from the ideal post-operative course that is not inherent in the procedure and does not compromise a failure to cure. So if we can agree what a complication is, now we want to know what our complication rates are, to quote for our patients. So how do we know what our complication rates are? Well, how do we know what we're going to put on the consent form? Any suggestions? So we could first have to think, there are so many different types of just, we're going to concentrate on pacemaker procedures because that's what I mainly consent for. There are so many different types of operation that trying to say what the complication rates from each of these individual types of procedure is challenging. We can go to the literature, and there are papers published which talk about the risks of procedures, but people don't particularly like reporting their complications where they can at all avoid it. In some of the older device implant studies, I'm sure that there is gross underreporting of complications of procedures. There are also big differences between complication rates in randomized trials versus real-world registries because different types of patients get recruited to randomized controlled trials. They tend to be younger patients with fewer comorbidities than do go into registries. So we can get the information from lots of different places and we'll get lots of different answers. So every time you do a research study, you'll find that there's a different rate of something. So here there's a hematoma 1.4% of these patients, 4% of these patients, not reported or none in all of these patients, only 0.5% of patients over here. So very different rates between the different studies. Now, part of that will be their threshold for calling something a hematoma. Some bruising is obviously part of the normal post-operative course. Some of it might be the case mix of the patients. If they were anticoagulated, for example, if they did more patients with atrial fibrillation, there is obviously the hematoma is a risk. It's not 100%, so you wouldn't expect a perfect distribution of risk across all the different trials. But the problem you've got is which one of these numbers, or do you just take the mean, do you take for your risk from a procedure? And here, this paper is showing us that in randomized controlled trials, these particular randomized controlled trials, the rate was very much higher than it is in a registry, 9% risk of complication versus a 3% risk of a complication. And their suggestion is that this is because of differences in reporting rather than real differences in risk, which just does seem like a very likely true statement. And as I've indicated already, there are lots of different papers. So this is another type of state-of-the-art paper. This is this time looking at ICDs versus cardiac resynchronization therapy devices. So, what in this previous paper I've not broken down for you, and I don't think the papers really broke down how many of these were single chamber, dual chamber devices, how many were septal leads, right ventricular apical leads. So loads of different additional factors in knowing how they can come out with their risk of complications. So what do you quote for the individual in front of you? And if we look at the difference between ICDs versus a biventricular pacemaker, there is apparently a higher rate of complication, but again, these are different trials, so they're potentially different cohorts of patients have been selected for each of these trials. So very, very difficult to know which of these numbers to quote for your individual patient. And the other big factor is operator experience. Any patient being reported in a trial is probably being done by a consultant that does quite a lot of procedures, because they tend to be the consultants that publish their figures. But what about if you're somebody who mainly does something else and they just do 1 or 2 procedures a year versus somebody who does quite a lot of procedures a year? Can you see that the mortality, it doesn't appear to make much difference, although that's a very hard endpoint, and 30-day mortality is too early, maybe even 90-day mortality is potentially too early, but hopefully that isn't impacted too much. But look at things like the risks of ICD infection. The rates are doubled if you look at the highest quartile of procedures versus the lowest quartile of procedure operators. And the rates of mechanical complications, again, considerably lower. So do you, if you're a low volume operator, tell a patient that their risk is considerably higher with you than with one of these? Or do you feel that you've done 10,000 procedures and therefore you've reached the point that if you're not doing quite so many a year, you're still better than the person who's only just finished their training and is still doing quite a lot of procedures trying to get their skills up to scratch? It cuts all sorts of different ways. And that's before you even start to think about having a registrar do the procedure, who even under direct supervision is going to take longer about doing the procedure. And it's likely that the risk is going to be affected to some extent by that. So how do we consent when we have got a registrar helping us with the procedure? We could also look at our own data. So our center is a big center. We put about the third highest number of devices in of all the centers in the UK. So we certainly do enough that we can get a good idea of what our procedural complication rates are like. This is an audit that I did many years ago now. And these are the sort of figures that we were getting out of risks. And what you see, risks at 1 year compared to risks at 5 years, these risks keep on changing. So when you consent somebody, are you consenting them for the operation itself, or are you going to consent them for the first year, the first 5 years, the next 30 years of their life? It's, what do you actually go through? Because you obviously have limited amount of time in clinic, and you're aiming for informed consent and understanding of what the procedure is and why, and whether it's right for them. But there's only so much information that a person can weigh. And just because these are figures for ourselves as a center doesn't mean that they necessarily reflect me or one of my colleagues, because this is the average across all of us. And each individual is going to have good years and bad years, because statistically they are, complications are relatively unusual, and there's going to be a standard deviation for how often they should have a complication. So it's going to vary. There are always going to be some people who have higher rates of complications and other people who have lower rates of complications. So if you start trying to quote your own complication rates, they might make you smile and be very happy for the first year, but the next year might be completely different. And if you do that, are you going to want to take on the high-risk cases that maybe really need the procedure but are inevitably at higher risk of complication? So very challenging to do something like that. And this is, if we look at rates of lead displacement, we can see that we tend to think of this as a very early event, but actually it does seem to keep on happening over time, even over the very long run. What is clear is if you have multiple leads, the risks are higher. It's a bit odd here that VVIR systems seem to do worse than dual chamber systems. But if we put in a 3 leads of the CRT, the cardiac resynchronization therapy device, which has leads in the right ventricle, left ventricle, and atrium, typically, we can see there's clearly a higher risk. So very difficult to know what to say in the face of all this. I hope you'll agree. So that's the sort of what to think about. That's what you can go through in coming up with things. Now I'll show you some of the complications and talk about some of the other aspects of device implant. So here, can you tell me what this would be described as? So this is a large hematoma, and I would describe this as being a complication rather than a sequelae. This is extending beyond the what you might expect from the procedure. You can see that whoever's done this has put staples in. This is not a procedure done in our center. This is a image I've pulled off online, but we don't use staples. We would tend to stitch up. Not that that is necessarily wrong, but the cosmetics are better. Can you see here? There's a scar up here. So this patient would have started with a pacemaker up here. This was probably the pacemaker box change being done, and it will have drifted a bit down their chest wall over time. And they'll have opened it up over the device, and you can see a big hematoma has formed. Now, these are generally best left alone, but if they are showing signs that the wound is under tension, is going to break down, and the hematoma is going to burst, that's when we have to go in and operate on them. Otherwise, just applying pressure to try and stop the bleeding from the hematoma is usually the best course, because often there isn't anything straightforward to do when we go in and evacuate the hematoma. And you risk reintroducing infection if you reoperate that. So it's if the wound is under tension, that's when we worry that it's going to burst open. And if that were to happen, then infection would get in and we'd have to take everything out. So we leave well alone if we can. And something to be aware of is that in the past, we always used to stop anticoagulants for pacemaker procedures, but a trial in the New England Journal called the Bruise study showed us that actually the risk of giving patients heparin and stopping their warfarin and bridging them with heparin around the time of the procedure was actually higher than the risk of carrying on warfarin. So we keep going with warfarin for procedures. There are different arguments for why this might be better. One is that heparin seems to be worse for causing hematomas around devices. It's quite a negatively charged molecule, and it may be that it attaches itself to devices, and it means that the concentration around the device is higher than it is everywhere else. It may also be that if you're stress testing your pocket by having the patient on the anticoagulation when you do the procedure, then you'll control the bleeding at the time of the procedure, and therefore it's less likely to bleed afterwards. But nowadays, I'm very keen that I want patients to be therapeutically anticoagulated if they need to be for the procedure. So if I've got somebody with a metal heart valve where they absolutely have to carry on the warfarin, then I carry it on and aim for an INR of around 2.5. I'd much rather that than to stop it, have them on heparin, and then end up having to put them on heparin and warfarin afterwards. If somebody's got a chance VAS score of 1 or 2, then for sure just stop the warfarin, because you don't need to bridge. But if you need to carry on the warfarin, that's when we would want to keep on going with it. DOAGs are slightly simpler in many ways. We tend to stop those the day before, so that they take it up until actually they could take it up until the day before, leave off on the day of the procedure, restart it the following morning, assuming all is well. If we're particularly worried that they're on antiplatelets, or they have low platelets, or there's another reason to be worried about bleeding, we might leave it off a little bit longer, but we're keen to get that restarted as soon as possible. I have done procedures on uninterrupted DOAGs. The reason for doing that tends to be slightly lower because it's so quick to get it started and stopped. So I do tend to stop that even if somebody's CHA2DS2-VASc score is, say, 3 or 4. But for example, if they've had a previous stroke and they have persistent atrial fibrillation, I would do them on DOAG, and I've not had any problems doing that, although the difficulties reversing it do make me nervous of recommending that. The problems are not just bruising around the device, it's also if you get bruising around the heart, that's the bigger concern. What about this complication? So can you tell me what this chest X-ray shows? So the silence that I'm getting tells me either you're all asleep or you are all not able to interpret this chest X-ray. Somebody suggested lead displacement. So I wouldn't be very happy if this was an X-ray of my patient because there is not enough slack on these two leads. You can see that they look as if you could twang them because they're under tension, and that's not good. But this is probably still in the right ventricle, and this is certainly in the right atrial appendage. So these leads probably haven't displaced, although we're a bit worried about the amount of slack. It is harder to put slack on the right side because the distance is shorter and too much slack is as bad as too little slack. So it is quite a difficult tension getting that right, but this person has not put enough slack on these leads. But this is not lead displacement. Can anybody else suggest a cause? Pneumothorax, very good. So look how the lung markings are present here and they're not present over here. And you can see the collapsed lung in here. So this is a large pneumothorax. So I don't like this when it's my procedure. Does anybody know what this is called? So I had my first one of these recently. It's a rare condition, probably 1 in 1,000 people. It's not something which we typically describe when we are implanting as a complication of the procedure. Maybe I should tell all my patients to watch out for it, but can anybody tell me what this syndrome is called? So this is an ICD, and the ICD lead is not supposed to be in the subclavian vein. It's supposed to be in the right ventricular apex down here. You can tell it's an ICD lead because can you see how dense white this bit is? This is because it's got a thick coil on that allows it to give a shock between there and the can. You can see the difference between the normal part of the lead and the ICD shock coil bit of the lead. If it's got a shock coil, it's an ICD. If it hasn't got a shock coil, it's not an ICD. So it's very easy to do a chest X-ray and know if your patient has an ICD or a pacemaker. So no suggestions there. This is called Twiddlers Syndrome. And what's happened is the patient has twisted the ICD or the pacemaker round and round and round, and that's had a capstan effect and put tension on the lead and dragged it slowly out of the heart and almost all the way out into the pocket. So they've done their own lead extraction. And of course, this lead is not working properly at all. So maybe I should tell my patients not to twist their ICD around in the pocket, but I don't tend to as a routine. So Twiddlers syndrome. What about this one? So as I'm sure you're all rushing to tell me, this is a device infection, and you can see a bit of the device is poking out through the skin, which is not supposed to happen. So this is the most devastating complication, along with the case vignette I showed you at the start, which is the even worse variety of this. You can have infection around the device and on the lead, but much more common is just to get infection around the device. Either way, it has to come out. At least if this infection is all round here, you can be clear of the infection in putting in a temporary system. But you need to ideally clear the system before the infection before putting in a new permanent system. If the device is, if the skin is discoloring over the device, that's a sure sign that it's going to erode out. And it almost always has to be infected in order for it to erode out, but sometimes in very thin people it can. The other thing is if the skin becomes adherent to the device, normally it should slide smoothly over the device, but if it feels like it's stuck down to the device, that again needs a revision because either it's infected or it's eroding its way out. So you usually see redness and erythema, and you might have systemic features of infection or you might not. Depends very much on what the bug is. If it's Staph aureus, which presents as a really vigorous infection with smelly, profuse amounts of thick green pus, then it's a very obvious thing. If it's Staph epidermidis, then you can just get a little bit of erythema around the pocket. But as soon as there is infection in there, you know the only way of getting rid of that is to extract the device. And extracting it is a big undertaking if it's been in a long time because the leads are very firmly stuck in. And we have to use special catheters that literally strip the vein from the lead, and they carry risks of damaging a great vein or tearing a hole in the heart, which means that there's a risk of about 1 or 2 in 100 of emergency major surgery, including about a 1 in 100 risk of death from doing a lead extraction if it's been in any length of time. So that's a very serious complication. And patients, when they're having a box change, their risk is about 1 in 100 of this happening. So it's not insignificant. We also risk causing a pericardial effusion and tamponade. So this is large pericardial effusion, and we can just about see the right ventricles collapsing here during systole. Don't worry about that. It's not a moving image, so I'm not surprised you can't see that so well, but that strongly suggests that the patient has got a significant pericardial effusion. Tamponade's a clinical diagnosis, so you'd expect this patient to be in a pretty bad way and need an emergency pericardiocentesis. I had to do one of those quite recently, and it's very hard to do that procedure in a very acute situation. So that's one of the complications that we most want to avoid. What about this complication? You may not be able to see so well, but can you look at the lead throughout the course down and round and here under the collarbone, under the clavicle, we have what's called subclavian crush. So the fascia here is such that it can put pressure on the lead and cause it to break. So we don't tend to go subclavian if there are other access options because of this risk. We tend to go axillary or cephalic, where the lead would be going in here or over here. So that's a subclavian crush. It can also happen over, sometimes the box can rub on the leads and can damage the insulation. And if blood gets into the lead itself, it will damage the lead. So the leads can fail over time. And can anybody tell me what this complication is? So our lead is supposed to go into the right atrium, and it's also supposed to go into the right ventricular apex. And this lead, rather than going in across the tricuspid valve, has gone through a patent foramen ovale and is now in the left ventricle. And it'll work perfectly well as a pacemaker doing that. The problem is that clots will form on the lead and the patient is at risk of stroke. So this is another thing that I wouldn't want to see with one of my cases, and I'd hope to avoid, because can you see that this lead is considerably higher up than it should be? It should be coming down here. So that would be another complication of the procedure. So Next, I want to show you something quite memorable. I want to show you a bit of a football match. And this is a Belgium football match. I'm sure you're all great fans of football, and in particular the Belgian version of it. And I want you to concentrate on this gentleman up here called Anthony van Loos. My apologies, the picture quality isn't particularly good, but it's just approaching half time. And I want you to watch him as he goes into VF and his heart stops. And he's completely clapped out. And then did you see his legs jerk? And then up he gets. A little bit shell-shocked. Shall we watch that again? If we come back, watch how, oh, I have to go backwards and forwards again. Watch how he's totally unaware of a problem, casually walking, and then he just out like that. That is cardiac syncope. And watch him, he jerks as the ICD fires. So that is him having his life saved by his ICD. And that's why ICDs can be such fantastic things. I don't know if you're aware of Fabrice Muamba. He was very lucky to survive having a ventricular arrhythmias and a cardiac arrest when he was playing for Bolton Wanderers. He had a hypertrophic cardiomyopathy and has had an ICD put in. But this gentleman has the same condition and had it put in prophylactically and was then allowed to carry on playing, which it's a very difficult decision, that. But he had his life saved by the ICD. But the ICD, just as it can fire appropriately, can fire inappropriately. And if you're having that jolt of electricity go through you, sometimes tens or even hundreds of times, because a lead gets fractured or you go into fast atrial fibrillation, can be very, very, very unpleasant. So inappropriate shocks is a sequelae of the implant. Another issue can be when we're putting in the left ventricular lead, what we do is we put it down the veins that go around the heart. We have to put it down a branch, and we're aiming for one that goes round to the left side of the heart, so one going in this sort of a direction. And in this patient, can you see there's a tiny twig here, which isn't big enough for me to put anything down. And here, this has got a real U-bend in it. That although it's big enough to put a lead down, unless I can straighten those kinks out, I'll never get anything to go down it. So this patient is likely to be incredibly hard to put a left ventricular lead in. And so a sequelae of me attempting a procedure might be I just can't do it because the anatomy is too difficult. Another one is that I'm expecting a patient to feel better having put in a biventricular pacemaker, but maybe they were too frail in the first place to benefit. Maybe their expectations were too high, or maybe they just don't respond. And probably about 7 out of 10 patients respond to us putting a biventricular pacemaker in. Sometimes the indication is very strong and they're more likely to. Sometimes it's a bit softer, but they want us to do anything we can to help them. And we might put it in with the knowledge that they were less likely to benefit. And another one is that pacemakers need to have their batteries changed. And as a rule of thumb, pacemakers might last 8 to 10 years, ICDs about 10 years. Biventricular devices, often you need a bigger burst of electricity to stimulate the left ventricle. So they tend to last less well, more like 6 years, but it depends. Sometimes you get a very good LV lead that happens, you can't know in advance, it just happens to work very well and it might last longer. But as the patient becomes older and increasingly frail, do we replace devices? Pacemakers, yes, we would by and large if there was a strong reason for the pacemaker. But what if they're bedbound in a nursing home? They're very frail indeed. What if when their pacemaker goes flat, they are going to have problems with recurrent syncope and feel very unwell potentially, but they're really too frail for even what is a relatively minor procedure. What do we do about our ICD if they've not had an appropriate therapy in the 10 years that they've had it? But do we then still give them protection going forwards, or do we say that the costs of a 10,000 device for somebody who hasn't benefited from it in the first 10 years have gone? Or what if they've become relatively frail that you wouldn't consider putting one in afresh, but now that they're 85 but they're still able to live just about independently, do you still replace their ICD? They're difficult questions. And it's very important when a patient is end of life with an ICD that we deactivate the ICD therapies. If we don't, about a third of patients have a shock from their device, potentially for ventricular arrhythmias, but they're dying. We can't stop them having ventricular arrhythmias. And instead of going peacefully, like you just saw Mr. Van Loo's, they end up dying of other things, or they die with their ICD repeatedly trying to shock them out of the arrhythmia, which is potentially deeply unpleasant if they're still conscious at the time, and is obviously unpleasant for relatives. The ICD can't give the relatives a shock. You can have your hands over somebody with an ICD getting shocked without you coming to any harm, but very, very disturbing if they're having ICD shocks. So critically important that if somebody has a terminal illness and is in the dying stage, that they have their ICD deactivated. Doesn't require an operation to deactivate an ICD. It's done wirelessly, but it has to be done in person. It would obviously not be ethically very safe to be able to have somebody deactivate your ICD from an office miles away. But it can be done wirelessly just by putting a wand over the ICD, and we can reactivate it again if the patient's condition improves. Maybe they've got COVID-19 and they're critically unwell with COVID-19, and resuscitation isn't going to help them. But having got through COVID-19 and recovered from it, it's maybe entirely appropriate for them to have it reactivated. The team can respond very rapidly because this is a really important thing for us to get right for patients. So, if we get told about a problem today, I could get the team out this evening to them if necessary. And the team, obviously, you don't want to go out on the evening on a Friday if they can help it. So please give us warning where you can. But the team can go to the patient at their own home to sort it out. And we can deactivate the ICD without switching off the pacemaker. So it can carry on working as a pacemaker and just have the shocks switched off. Pacemakers, on the other hand, I sometimes get asked to deactivate a pacemaker, and the answer to that is almost always going to be no. And the reason for that is that it's not that straightforward to switch off a pacemaker. They don't have a simple switch to put them off because they're really not designed to switch off completely. You can turn their rate down to 30 quite easily, but a rate of 30 is enough to make somebody feel very unwell, but not enough that they die from it. So it's not really switching the pacemaker off to just turn the rate down to 30. So it's really not straightforward to do, and I would be very resistant to anybody asking me to do that. Because I would expect them, if they're depending on the pacemaker, for it to cause them very distressing symptoms. And I think the ethical issues associated with that are quite complicated. So if I had somebody come to me saying they had a terminal illness and they wanted to die, and that I was keeping them alive with my pacemaker and they've got a right to refuse treatment, I would be really torn up by having to work through the ethics of that, and I would not rush into anything. The problem is switching it off is not likely to mean that they just die suddenly. It's likely that they would have a complete heart block and pauses, and they'd recurrently black out and feel dreadful. So it's not a straightforward thing to do. The only time I've ever been asked to do that is by ITU, who wanted a bed, and I said no. Because I didn't think that that was the best way forwards. So what do we actually say to patients? For example, this is our sticker that we have for cardiac resynchronization therapy, implantable cardioverter defibrillator, or CRTD for short. Um, we have a sticker because it's really useful for everybody to be on the same page with what they tell patients as a department. It's really useful to have something legible put on the consent form. It includes the benefits, serious or frequently occurring risks, and it talks about some of the risks of complications that I've gone through. It also talks, which I didn't mention to you, about the risk of cancer associated with the X-ray exposure, and it also covers things like blood transfusion, which is clearly potentially a thorny issue. It's very unlikely with any sort of pacemaker procedure. So we, very importantly, you consent patients in advance of the procedure, and you really should be giving them the information before they attend on the day, because it's too late to expect somebody to make informed consent on the day of the procedure. So we give them information in clinic in terms of a booklet and a chance for discussion. They then might sign a consent form in clinic on that day, but take it away with them, have chance to read it. They have chance to change their mind. When they attend on the day, we re-sign the consent form to say that we've gone over it again, the patient is happy. And in between times, patients get seen by the arrhythmia team, who spend a lot more time than I have with the patients, really doing a great job of consenting and going through all the issues and practicalities on the day, what actually happens during the procedure, and the implications for patients' lifestyle, and things like driving, which are very important to tell patients about. So we do a thorough job, hopefully, of consenting patients. So I hope that that's helped you think a little bit more. I was very much wanted you to sort of see the general ideas behind consent, rather than just tell you what the risks of a particular procedure are. And I hope you've also learned a bit about ICDs and pacemakers, and in particular, remember that ICDs need to be deactivated if your patient is at end of life. Thank you very much for listening. Next week, I'm going to teach about endocarditis. Have we got any questions before we close?